Approximately 1.5 million traumatic brain injuries occur per year in the US alone, which makes it one of the leading causes of death, especially for males under 45. Extreme sports or traffic accidents next to gender and age are the risk factors for TBI. TBI is about 8 times as frequent as breast cancer, AIDS, spinal cord injury, and multiple sclerosis combined. This is 28-year-old patient F, who had a motorcycle accident. The consequences: severe traumatic brain injury in form of hemorrhage with mass effacement of the ventricles and a fracture in the frontal skull base and right temporal bone. In TBI, a distinction can be made between open and closed head injuries. In open head injuries, the skull is penetrated, for example through a gunshot or fragments of bone entering the brain. Open head injuries usually do not cause the victim to lose consciousness. Closed head injuries are caused by a blow to the head, as with patient F. They cause a coup, an injury on the side of the blow, and a contra-coup, in which the brain collides with the skull on the opposite side. The brain movement can cause twisting or shearing of nerve fibers and create microscopic lesions, which are most common in the frontal and temporal lobes. If the anterior commissure or corpus callosum are damaged in this way, it might lead to disconnection syndrome. Bruises and strains might create a cerebral hemorrhage, and the blood trapped within the skull can produce a hematoma which exerts pressure on surrounding structures. Another source of brain pressure can be swelling, also called an edema. Consequences of TBI mostly depend on the site of the lesion and the severity of damage. Even though specific damage can produce distinct symptoms, some symptoms are commonly seen in patients with TBI. Among these are predominantly cognitive impairments in the domains of memory and concentration, and psychological complaints such as fatigue, anxiety, irritability, and mood swings. Headaches, dizziness, and blurred vision are also frequently reported. Damage to temporal and frontal lobes is associated with impairments in personality and social behavior. 1 year after injury, patients usually report less symptoms than at the 1-month mark. However, some may also report new symptoms, reminding us of how different the path of recovery is for different individuals. The most distinguishing long-term consequence of severe versus mild TBI is the extent of memory loss. Another commonly observed consequence of TBI is depression. As many as half of patients 3 months after injury qualify for a diagnosis of depression, highlighting the importance of psychological treatment. Only few of the affected can resume higher education and are usually afterwards employed in a lower level than before. Once people had a TBI, they will likely get another one because behaviorally they might be more careless and effects of even mild TBIs are cumulative. The severity of a traumatic brain injury is assessed through the degree of unconsciousness in a coma or the duration of amnesia. The extent of a coma can, for example, be determined with a Glasgow Coma Scale. This test has 3 scales that assess eye-opening, motor response, and verbal response. A score below 8 indicates a severe closed head injury, whereas a score between 9 and 12 hint to a moderate injury. A limitation of this test, however, is that half of the head injury patients in hospitals score between 13 and 15, which indicates the absence of a coma. But those same people may still experience consequences of their head injury at a later point in time. The extent of a traumatic brain injury can also be assessed by determining the length of the post-traumatic amnesia. The idea behind this behavioral assessment technique is based on the correlation of post-traumatic amnesia with later memory disturbances. Thus, a very mild injury is associated with amnesia that persists for less than 10 minutes. A very severe injury is linked to amnesia that lasts more than 7 days. Since this assessment is not standardized, the results of observers may vary. Recovery from head trauma may take 2 to 3 years, but the bulk of cognitive recovery takes place in the first 6 to 9 months. Memory is restored more slowly than general intelligence, and one's ultimate memory performance is usually worse than before. In patients with prominent impairments, cognitive skills are likely to recover well, whereas social skills and personality may remain impaired. A few days after the incident, generally brain areas that are still functional increase or reorganize their activity. In some cases, certain areas take over the function of those areas that are inhibited due to the damage. This change in structure is then followed by regrowth of axons and axon sprouting. To compensate for diminishing input from damaged neurons, other areas adjust to maintain the level of natural arousal. In general, recovery from damage to the brain depends on the learning process. In open head injury, distinctive symptoms are often seen that undergo rapid or spontaneous recovery. The symptoms are usually very specific, like in a surgical excision. Since TBI frequently causes lifelong impairments, prevention is of great importance. Creating awareness that concussions have long-term and cumulative effects is therefore the key point. In sports, appropriate rules should be adapted, safe coaching should be implemented, and protective headgear should be developed. Prevention strategies also exist for traffic, combat, and the workplace.
Treatment of TBI requires the interdisciplinary cooperation between professionals. Medical professionals are required for treatment of the injury as well as its ongoing supervision. In this medically dominated field, how do you see the role of the neuropsychologist in the care of TBI patients?